Hello, PTAs. I hope that you guys are doing good. And today we are going to talk about biomechanics. Okay, so first we're just going to cover some terminology, basic terminology. Mass is the amount of matter an object has. Center of mass is the balance point of an object. So typically for us, it's somewhat of the middle of our body. Typically it's low towards the pelvis and maybe in front of the spine. The center of mass changes based on your weight and your body distribution. So if you're built really big up top and small in the bottom, it's going to be completely different than somebody that's small up top and big in the bottom. The mass does not change regardless of the position or of external influences. So how much matter an object has does not change. However, gravitation's pull on that object changes as you change position. So your center of mass, or also called the center of gravity, changes when you change positions. So as you see in this little picture, it's kind of in the middle of his pelvis, and then it goes up higher as he lifts his arms, and it goes forward even in front of his body when he bends into that third position. So your center of mass also changes when you add or remove weights, like if you have a backpack on, or if you're carrying a baby, or if you sit the baby down. That changes where the center of mass is. And then segments are just talking about your body parts. They can be looked at individually or as a group, and they each have their own center of mass. So if we were talking about a foot, it would have its own center of mass, or if we were talking about the entire leg, it would have a different center of mass, the entire body, a different one. So you kind of have a center of mass for each segment of the body in order to know exactly how the weight is distributed in a balance point around that. Forces. A force is just a push or a pull that creates an action on another object. There's linear forces, so just straight. There's rotational forces, so a linear force would be like that. There's rotational forces where it spins. External force would be like me pushing on this phone, and internal force would be like me moving my arm. The internal force, it's being moved by my but my muscle is the word I was looking for, by my muscle rather than an external force of my arm. And I thought I had a picture I put on that slide. Oh, it's on a different one. All right. Okay, so common force is gravity. We all know gravity is the force that holds us down on the earth. But friction, remember, friction is resistance to movement. So typically it's on an object's surface. So as something is moving, eventually it's going to come to a stop, and that's because of the friction from that surface. And the definition is force resisting between two contacting surfaces, providing resistance between those contacting surfaces. Gravitational pull is important because it's needed for loading. So if you never put pressure on your joints, on your bones, or whatever, they will not actually grow and get strong. So in order for everything to strengthen, like standing, for example, helps you reabsorb more calcium in that weight-bearing position into your bones than if you were on bed rest. So when you're on bed rest, you lose more calcium. Hold on. Sorry. Than if you were standing and doing your normal activities. That helps you reabsorb calcium. So gravity can be a good thing. But for somebody who's really weak, they may not be able to stand against gravity, so it could add a challenge. There are AlterG treadmills for people like that could help them. And then friction. If there's no friction and we're walking somewhere, or your shoes are really slick, you're probably going to slip and fall. But if there's too much friction, you're probably going to trip. So you have to really find that happy balance of both of those for your patient, depending on their needs. Okay, so a vector is just an arrow on a diagram that is used to represent linear forces. So the tail is actually the starting point. It is the initial point. The line goes out that way, and the arrowhead is the arrow at the end. And typically, so they'll show the line of action. So it could be the line of action of a muscle or of gravity, which would go straight down. And if the line of muscle is parallel to the ground, so it could be parallel to the ground, and that would be in the transverse plane, as you see the transverse plane. Hold on. Blank. Transverse plane. Or the ones that are perpendicular to the ground, up and down, whether it's this way or this way, would be the sagittal and frontal planes. Okay, so a moment is an angular force. It's created when a linear force acts at a distance from an axis. So if I was holding my phone here, right there, that would be my axis. And if I pushed it in the middle, it would not do too much. It wiggled maybe a little. If I push it at the end, it creates a big movement. That is a moment. So the further you get from the axis, the bigger movement. If I get right here close to the axis, it doesn't move very much, but further away, I can make a big movement. The moment arm is the distance that is between the axis and wherever you're touching, wherever the movement occurs. So if it's right here, it's a short moment arm. If I move all the way out here, it's a longer moment arm. So the moment arm is the distance between the axis and wherever your force is applied. So if the linear force acts directly at the axis, probably nothing will happen. But the further away, the greater force. Okay. And then that angular force that creates a movement is called a moment of torque. These things are just kind of at the bottom of this are just for your information. You don't have to know that for a test. But once again, as I mentioned in a different slide, but I want to mention again, the forces could be external or internal. So right here, she is pushing with one arm and moving the other arm. That would be still an external force. If I'm just sitting still, I don't activate my muscle, and all I do is come and do what we call passive range of motion. That's an external force that caused that to move. And that would be, the moment arm would be between my elbow, where the axis is, and my hand, wherever it pushed. Versus if my bicep actually activated and pulled my arm this way, then where the bicep connects on the bone is where the force is. That's where the force is being generated, where my bicep is connecting on the bone. And so the moment arm would be a lot shorter. Okay, and here's what we came to talk about: body mechanics. Body mechanics are just the way we position our body during a task. And it affects our movement efficiency and the amount of stress that we place on our body. It's very important because this is what protects you from getting hurt while you're moving patients and doing patient care. Low back injuries are really common among PTs, nurses, a lot of people in the healthcare field, and so it's very important that you especially protect your low back, but you want to protect your shoulders and everything else as well. And so teaching healthcare workers the proper form with moving patients and doing all their tasks that they're going to do on a daily basis is key to avoiding those low back injuries. I know I started out in nursing school, and by the time we got to our clinicals, we had never learned anything about body mechanics as far as it might have been written in a textbook, but practicing holding the right position, practicing moving a patient, or being told how to stagger your legs so that you can shift your body weight rather than just using your arm strength. And it is very, very common for nurses to get back injuries. I mean, they're moving patients all the time. And I kind of wonder, if that could be part of it. Maybe it's not stressed as much in nursing school than PT school, but I do know at a lot of hospitals they're starting programs where they teach, and sometimes it's the PTs that might lead that program. They teach other staff members, primarily nurses and CNAs, how to properly move the patient. Okay, so in this picture, the arrows are called vectors. Okay, the arrows are called vectors, and so the vectors are showing us kind of where gravity is. So gravity is pointing straight down, and the line of pull for the erector spinae. Of course, they are the main thing that keep your back in an extended position, your erector spinae. Okay, the red circle is the axis. And the first picture is showing you wrong. This is not good body mechanics. The second picture is good body mechanics. So in the first, she has her knees straight. She has her axis and really her full body far away from the patient. She has a lot of room right here between her and the patient. And she's bending at the waist and back. She's bending through her she's just flexing the trunk in order to get to the patient. And so the center of mass is more anterior in this picture. This line of gravity is coming from where her center of mass is in that position. And the hat, which is the head, arms, and trunk, is being fully supported by the erector spinae muscle. So all the weight of it is against that muscle. That muscle is responsible for holding up all that weight. And of course, if the therapist moved the patient in this position, that muscle would also have to hold the patient's weight. So it's a lot of pressure on the therapist's back in that position, and that is how low back injuries happen. So the main thing that you want to do differently, you want to stagger your legs, wide base of support, and stagger it a little bit so that you can shift forward and backward, side to side without losing your balance. And then bend your knees and keep your back straight. So the movement comes more with your leg muscles, which is a larger muscle, less likely to get injured, than with your back. But also look at the moment arm, because gravity's pull is now so much closer into her body based on her base of support. The moment arm in the first picture is pretty long, and in the second picture it's at least half that. And so then that means that it's putting less stress, less force on those erector spinae muscles. And then she's able to pull the patient up with significantly less force on those muscles, much less likely to get injured in that position. With a force couple, this is when muscles act together in order to move around a pivot point. So with if this is the pivot point and it's straight up, then one muscle would pull while the other muscle pushed. It's kind of hard for me to do it with that, but while one pushed that way, the other would push in the opposite direction in order to move it. So it's typically in the opposite direction around an axis. So if it was a pin or something, of course I don't have one right now, one force would be going that way in that direction, can't hold it, and one that way to spin it in opposite directions. One thing that we see in real life that is a force couple we see people doing is if you want someone to scoot forward in their wheelchair, they will lean back and push their back against the back of the wheelchair, and then that will cause their legs to slide forward to the front of the wheelchair to prepare to lean forward and stand up. And that is a force couple that they're using around an axis, like the middle of the spine, to shift their weight forward. So try that. If you're sitting in a chair right now, lean back and push your legs forward, and then try and lean forward and scoot forward. It takes a lot more muscle. Okay, there's various types of loads. A load is just a force that is placed on something. So a tensile load pulls apart, adds tension. A compression load pushes something together towards each other. A distractive load also pulls apart, but it pulls two surfaces apart, typically at the joint. You're pulling them and opening the joint space. A shear is putting pressure typically at the same point in the opposite direction. So if I was pushing down and up at the same time, in the same point, let's say on a piece of paper, that is a shear force. Shear forces aren't good. Typically they kind of cut and tear an object. So you have to be really careful about shear forces. Good way of getting injured. Bending, of course, flexing an object, moving it, and then you can combine any of these loads to do any movement. So whatever movement that you are doing, you can combine. You may be flexing and bending and all those things together. Okay. All right, so managing load. So stress is a force applied to one area, and then strain is the change to that area due to the force. Okay, so if I am pushing on, I'm trying to find somewhere kind of cushy, something right here, the stress would be me pushing through the finger, and then the strain is that dimple that's created in my muscle that you can see as I push. Pressure is the amount of force across an area, and the amount of force you apply and the speed of force, the speed in which you apply it, has a great impact on how the tissue responds. So when you apply force through a small surface, like if you are massaging in the picture, if you're massaging someone and you apply it through your elbow, just the point of your elbow, one, it's going to be super uncomfortable, but two, it's going to increase the amount of pressure at that location because it's all applied to one, versus if you apply it through your full forearm or your whole palm, then it's going to increase the surface area that you're applying force to and disperse the pressure evenly along that area so that it's less force. So it's a lot more comfortable for a patient if you massage with your forearm or with your palm with a full surface than with a point of a surface. The other thing is that tissue requires time to respond to loading. So when you apply a force slowly, then it allows time for the tissue to respond and then to that increased stress. But if you apply it too quickly, it doesn't allow time to respond and it can damage the tissue. We have Golgi tendon organs in our body that respond to changes in muscle length. And if your muscle is pushed too quickly, there's a reflex that happens at the spinal cord. It's not even coming and being transmitted by your brain. Your spinal cord is taking care of it, so it's faster. And it's the stretch response, where if I apply a quick stretch, my arm automatically locks up and the muscle automatically contracts in order to counteract that. So that's one of our protective mechanisms to keep us from getting injured. But even with that, if you apply too much force too quickly, it's very easy to get injured because your tissue doesn't have time to respond. So think of like a power lifter. You know, if he just lifted the weights really slowly, he may not be able to get them up, but if he lifted the weights really slowly, then his body has time to react. If he just clings and jerks, does a really quick movement, then he's much more likely to get injured because his body does not have time to react to that change. Effects of loading. So loading is a good thing. This is how we get stronger. This is how we build muscle. This is what we're doing when we're exercising. We're repetitively loading an area. If you load too little, that causes atrophy. Like if you're on bed mobility, if you're immobilized, whether it's bed rest or in a cast or something where you cannot use a certain area, or you're not able to get up out of bed in order to load and put pressure and stress on the muscles, then eventually they are going to get smaller and atrophy. That means get smaller, just kind of start to die off. They don't fully die, but they just get smaller and smaller and less strong. Versus if you put too much stress on something, for example, if someone's pushed hard and it all of a sudden, and then they start to fall. So it could equal an injury. The fall itself could equal an injury, or if they have a sudden fall anyway, and then all of a sudden there's a lot of stress out of nowhere, that would create an injury as well. Any sudden force on something could create an injury. So you have to find the appropriate amount in order to maintain your bone mass, allow your tissues to grow and heal, and to promote function without overloading and causing an injury. Here's a few examples of loading structures if the loading went wrong, what it would do. So one example is the spine. If you excessively flex the spine, so if you're always sitting in a hunched over position and you lift too much weight in a flexed position, it increases the shear forces on your spine and may cause a disc bulge. So a disc bulge is the soft disc in between the bones in your spine pushing out. So it's supposed to sit evenly across the bones, and it's pushing out towards the back. And the way we counteract that is by having good posture and good biomechanics. Another example is skin. If you slide in a bed, especially someone like an elderly person with thin skin, if you slide up and down in the bed, it creates friction and a shear force to the skin and can tear the skin. And the main way that we counteract that in hospital or nursing home settings, things like that, is using a sheet to slide a bed and to do transfers. So in this picture, you see the green sheet, the healthcare workers on each side of it are holding the sheet, and they bend their legs and move the whole sheet with the patient on it, so that the only thing that is shearing and having friction against each other are the two sheets, not the patient's skin against the sheet. And the last example I'm going to go over is the shoulder. After a stroke, people often have hemiplegia, weakness on one side, and specifically the shoulder is easy to injure in that because none of the muscles are strong enough to counteract any force. And so if you were to pull or tug on that shoulder, it could dislocate very easily. And the main way we counteract that, sometimes they'll have to wear a brace or something, a sling to keep their shoulder in a good alignment so that it doesn't come out. And also we use the trunk for position changes. We don't get up under the arm and change positions there. We don't grab the patient's hand and jerk them up. We use the trunk to help them change positions. Okay, so stability and mobility. Some of the terms for stability. Stability is how well something stays put. Mobility is how well something moves or can be moved. The base of support is the contact an object has with the supportive surface. So typically for us, it's our foot on the ground. It could be other things like the base of the wheelchair. If you have crutches, those are included in your base of support. But anything that's contacting the support surface would be your create your base of support. So even if you think of like a picture frame and it's open up and sitting on a shelf, the shelf would be the support surface, and how wide the picture frame opens would be the base of support. So the smaller, more narrow a base of support is, the less supportive. So if you're standing on high heel shoes, you're more likely to fall over because you have this little tiny base of support under you, especially if you're standing on one specifically. If you're standing on 1 foot versus 2, your base of support has narrowed greatly and you're more likely to fall. Versus a larger base of support is more supportive. So if you stand with your legs a little more wide or staggered apart, it can really increase the base of support and your stability, make you less likely to fall. Another thing that we use this for is transfers. Increasing your base of support allows you to shift your weight side to side, front to back, so that you're able to take on the extra weight of the patient and move them where you need to without hurting your back. So we widen our base of support and have a lot of wiggle movement that we can lean towards without losing our balance. Now below I have the conditions for stability, conditions for mobility. So if you want to be more stable, you have a larger base of support. You have the line of gravity is near the center of the base of support, and then the distance between the center of mass and base of support is shortened. For mobility, you have a smaller base of support. Line of gravity is allowed to move beyond the center of the base of support. So every time you take a step, you're kind of moving out of the base of support, and the distance of the center of mass is above, a little higher than the base of support. The other, when I said the distance is shortened, it's lower, so like bending your knees to be closer to the ground. All of this is in the book spelled out for you there as well, but if you wanted to pause it and take a closer look at those, feel free. Okay, stability and mobility. So dynamic trunk stabilization, that is maintaining good spinal alignment while you're moving. A lot of places it's referred to as neutral spine, maintaining a neutral spine, or neutral pelvis or pelvic neutral. And how it basically means the deep core stabilizers, which the primary one is the transverse abdominis. It's one of my favorite muscles. You'll hear about it a lot in the program. Are contracted in order to support the spine and keep it in a good alignment while you're moving. Okay. So your spine is not leaning towards flexion. It's not leaning towards extension, but it's right in the middle, kind of that sweet spot. Same with the pelvis. The pelvis can be anteriorly tilted, leaning forward, or posteriorly tilted, leaning backwards. But with a dynamic trunk stabilization, you want it neutral, right in the middle in that sweet spot. Controlled mobility is when you are intentionally moving your line of, is it line of gravity? Line of gravity? Sorry. L-O-G-E, line of gravity, I think. Yes, line of gravity. Some of these abbreviations get me from time to time. Okay, intentionally moving your line of gravity outside of your base of support. So walking would be an example. You're intentionally taking a step outside of your base of support in order to move. That's called controlled mobility. Uncontrolled mobility is when you move too far out of the base of support and you fall. You're too far out of the base of support and you can no longer control that movement. You lose balance. That would be your uncontrolled mobility. One thing I wanted to talk about is this proximal stability before distal mobility, and your book has it in a different little saying in order to remember. That's how I learned it at school. And you want to basically contract your deep core muscles before you move a joint or an extremity. Same with, even if we're talking about an extremity, you want to get good stability at your shoulder before you reach for an object, because if you don't have good stability, you go to pick a cup up, you're going to be shaken, or you're going to miss and overshoot the cup, or things like that. But that part we'll cover more in Rehab 1. So the main thing here with dynamic trunk stability is that you want to contract those central muscles before activating the more distal muscles further away from the trunk or closer to the outside of the arms. And that way you are stable and able to move those where you want to go without being uncoordinated. All right. Okay, applying biomechanics to an assisted transfer. So for positioning for stability. So first off, you want to make sure you're stable. If you start to lose balance while you have somebody else's weight, watch out, because now you're both about to get hurt. So you want to widen your base of support, stagger your legs if possible. Your center of mass is low towards the base of support, and so bending your knees. The patient center of mass is also low, almost directly over their base of support. Typically, we have them lean forward. We'll say nose over toes so that they lean forward. If they're leaning back, it's almost impossible to lift them up because all their weight is right there on their butt. If they lean forward, their butt can lift up. We call that the head to hips ratio. So if I want to take weight off my left hip, I would lean to the right, and now suddenly I can get a hand under my left hip if I need to. If I want to take weight off of my right hip, I would lean the opposite way. If I want to take weight off the back of my hip so I can lift it up, I need to lean forward. Head to hips relationship. So, in ratio. And then the distance between the caregiver and patient needs to decrease as much as possible while still allowing the movement. So they'll still need to have enough room that they can lean forward and perform the movement, but you need to be as close as possible so that you can lift them up with less stress on you. So even if it's a box, if anything you're lifting, the closer you get it, the less force, because we've decreased that moment arm. Okay, I'm recording this at home and I keep getting interrupted, so sorry, I keep pausing the video if you're wondering what's going on. More applying of the biomechanics. So blocking the knee. If you block the knee, you can help direct the force. So let's say you put them back in the wheelchair and you want it to scoot them back towards the back of the wheelchair. You can push forward with your knee right on their knee, as long as they're leaning forward. Then for one, it can create a force couple, so it's easier to push back. And two, the movement through your knee and through theirs pushes their femur, their whole leg, back towards the back of the wheelchair. We can practice this in lab as well. You also sometimes will need to block the knee in a standing position, like if the knee's buckling, if it's so weak it's buckling, you will stand with your legs right in front of the patient's knee to block it, to keep them from falling down from their knee blocking. Okay, nothing else I need to say there. Okay, so laws of motion. I don't care that you know these too well, but you need a little bit of a basic understanding just so that you know what you're doing with kinesiology and things like that. So the first law, body's at rest, stay at rest. Body's in motion, stay in motion. So inertia is the ability to resist change to motion. So each object has its own inertia, how much it can resist. If I have this scrunchie, it takes very little. I could probably blow it and it'd be moved. If I have this water bottle that's full of water, I have to push it pretty hard to move it. Blowing it doesn't really affect it. So that's the amount of inertia inside of an object. Second law, acceleration is inversely proportional to the mass of the body. Again, this has very little mass, and so it has very little inertia, and it can be moved easily. This has a lot more mass, it has more inertia, can't be moved as easily. So if I'm pushing a little toddler, I could push them in a stroller very easily. If I'm pushing a bariatric patient, that's someone who's morbidly obese in a wheelchair, it's going to take a little more strength to push them because of the amount of mass. The relationship of force, acceleration, and mass all determines the motion. So how much force you apply, how quickly you apply it, and how much mass or matter is in that object to resist that. And then the third is about that resistance, that every action has an equal and opposite reaction. So if I'm pushing the water bottle, the reason it's not moving is because it's heavy enough to push against me. And if I, let's say arm wrestling, if I'm arm wrestling somebody and I'm not getting anywhere, even if I am, there is something pushing against me. Okay, and if you overcome the amount of push of that object, right here, I'm pushing it hard enough, now it's moving, then you get a movement, and if you do not, it stays still. So an example of the first law, let's talk about a ball here. If a ball is sitting still and nothing, no force, no wind, nothing comes along to set it in motion, then it will not be set in motion. However, once it is pushed, it's going to remain in motion, until something stops it. It could just be the friction of the sidewalk or the grass or whatever it's rolling in. It could be actually an object in its way. The second law, the acceleration is inversely proportionate to the mass of the body. An example of that would be pushing a tennis ball, pushing a medicine ball. Okay, so if you're pushing a tennis ball, you barely flick it and it rolls. If you're pushing a medicine ball, you can push it. It's got more weight coming against you, and it's going to take a harder push to roll. And then the third law, when pushing an object, so like that medicine ball, it has some pushback. It has some resistance to that movement naturally based on its mass. If you have questions on that or anything else on the side, please let me know so that it's clear. But you won't see a lot of, you don't need to like memorize every word of those laws. Muscles acting on bones. So now here's more PT related things. Closed chain exercises. Those are weight bearing. So that is when the distal end is stable, so like your foot on the ground, and the proximal end moves, so like a squat or standing and sitting. So the top of the body is moving while the feet are remaining in the same position. Those are called closed chain exercises. Squats, lunges, weight shifts, things like that are all closed chain. Open chain exercises is in a non-weight bearing position, and the upper portion, the proximal end, is stable while the distal end moves. So if you're seated or you're laying down and you're doing leg kicks or leg lifts or anything where you're moving the foot, but the hip and the trunk are staying in one position, that is an open chain exercise. So the proximal end, your trunk, is stable, and the distal end, your foot, your lower leg, is moving. Osteokinematics are the movements between bones. Typically, we're talking about long bones. So one example would be the radius moving. The radius is right here on the thumb side because it's rad. The radius is right here, and as it moves when you're doing bicep curls, that is a long bone moving. We can see that movement and we can name it. Right now, we would say that it's moving more anteriorly and now more posteriorly. And remember, anterior and posterior are always related to the patient themselves, not to your view of the patient. Versus arthrokinematics. Arthrokinematics are movements between the bones. Typically, this is in joint surfaces, and they allow the larger bones to do their full movement, but they're not under voluntary control. We can't typically view them with our naked eye. There's skin and stuff covering that, and most patients aren't aware that they're even doing it. So as we lift our arm up to reach for something at the shoulder, your shoulder is a ball and socket. It must roll. It must glide. And the long bone must move. So if this is the ball, the socket right here, this is the ball, this is the top of the humerus, and it's moving forward, so anterior, like flexion, just like that, and it's moving forward. We would say the long bone is moving forward. This is a convex surface moving on a concave surface. The long bone is moving anteriorly. The roll is also anterior. Think of a ball rolling. Whichever way it's moving towards, the roll is going towards that direction. Okay, so if I'm going, right now we'll just say up. If I'm right here and I'm going up, the roll is also going up. And the glide is in the opposite direction. This is when I'm talking about a convex surface moving within a concave surface. It's in the opposite direction. If I just kept rolling without going in the opposite direction, I would roll out of the joint. My shoulder would just dislocate. It would just roll right off the joint. So in order to stay in the middle of the joint, it must glide in the opposite direction in order to stay right in the middle. So as I'm going, we'll call this up for the sake of ease. As I'm going up, I'm rolling up, but I'm gliding down in the opposite direction. Now, if it was the concave surface moving, everything's in the same direction. It's like a wrench. What is that? Is that, I don't know what type of wrench that is. I'm not good with tools, but I think it's a socket wrench. If it's going, now it's going up, everything's going up. the roll, the glide, everything's going in that direction. It's pushing the whole screw in that direction because everything's moving in that direction. That is if the concave surface is moving. Okay, so if you have questions about that, please ask me about that too, because that's something you're learning in kinesiology that can get really confusing. But those are arthrokinematics. Roll, glide, spin are our arthrokinematics. It's not under voluntary control. The reason you need to know them is because that's how we determine what joint mobilization to do. If somebody's shoulder is stuck and they're not able to flex it, we can do a joint mobilization where we stretch part of their capsule and it frees up their movement within that so that they're able to now do that movement. That's why it's important to know and understand those arthrokinematics. But what we see are osteokinematics, movements of long bones. Okay, the big movement you see is an osteokinematic. Okay, so a few quick guidelines for your good body mechanics. We will practice these in lab. Plan ahead, so figure out how am I going to move the patient, where I'm going to move them towards, how should I stagger my legs so that I can turn towards the right direction. Position yourself close to the load. Always bring it close to your body. It will have a shorter moment arm and therefore less torque or stress on your body. Widen your base of support. Get really good and stable. Maintain normal spinal curvature when possible. So remember the dynamic trunk stability. Make sure your core is nice and stable before you move. Bend the hips and the knees. Don't bend at the back. Hold the object close. We just said. Set the trunk muscles. That's kind of contracting the transverse abdominis, contracting those deep stabilizers. One way that you can, just a quick way you can contract those is for a guy, one way that they typically relate to is tense up like you're about to get punched in the stomach. And that is contracting that deep core stabilizer, transverse abdominis. Women can relate sometimes to like zip everything up towards the middle or perform a Kegel and zip towards the middle, perform a Kegel. When you perform a Kegel with it, it helps it contract more because all of that works together. And we'll talk about that in Rehab 1. We'll talk about that several times throughout the program. But we want to contract those muscles, and then the larger muscles will do the work. We don't want to use the rector spinae to move a patient. We want to use our quads and our hamstrings. Exhale during exertion. You've heard weightlifters do that. Avoid twisting at the trunk, especially when the trunk is flexed or when you have a load, when you're carrying something. Instead, move your feet where you need to move rather than twisting at the trunk. Push rather than pull. It's a lot less strain on your body. And if in doubt, get some help. If you need some help, if the patient's a little big or you've never transferred them or you're a little worried about how any movement that you need to do, get some help. Get a second person so you're not stuck with that load. That is our play posit for today. Please let me know if you have any questions, and I will see you in lab. The rest of your readings we will go over in lab this week.